So now we're going to go over admit slips and permanent patient records, release forms, stuff like that. So to start out, admission forms and our consent forms are all tied in together. So this is for a spay that will be coming in a couple of days. We have the client's information here, the patient's information here, and then we always write down what the patient is being seen for, and then any additional testing that the owner approves. This is just saying that the owner is responsible for any billing. It also states that they understand the risks of any anesthesia given to a patient. They also understand that surgery or treatment we cannot guarantee a specific outcome. It also talks about that they are not responsible for the safekeeping of the pet while they're here. That is our job, but that is our admit slip. So in order for us to know exactly what to put on the line, for instance, this one's coming on for a spay. So we know that we're going to do a spay and anesthesia. That's a given. Hopefully they'll do medications. Sometimes we do have some that decline medication, so I do usually wait to write that down until I go over the estimate with the owner. So going over the estimate, we like to start with the main thing that they're here for and then give some options down at the bottom. So we kind of start from the beginning to the end of the visit. So we're here for a feline spay. It's going to get anesthesia. We highly recommend IV fluids during the surgery, and we do explain to the owner that it helps keep the patient hydrated, and it gives us a direct port into the vein if something were to happen during anesthesia. So it is optional for us, but we do highly recommend it, and we do usually have a lot of people that do it. So. And then we have they're going to be using an operating theater, surgical pack opening and autoclaving, surgical assistants, not any charge to them. It's just for us so that we can keep track of everything that we're using. Then we have our pre-surgical blood work. So this is a young patient. She is 6 months old. So we would do the minimum database for our clinic, which is a CDC and a Chem 10. We have two different options. They can do it in-house the day of surgery, or if they want to bring it in ahead of time, we can send it out to IDEX, and it saves them a little bit. So they have a few different options there. We also offer laser progressive healing with a class 4 laser. We give a penicillin injection after surgery. For pain medication, they have Onsior, and then we send them home with an e-collar. So that is our admission form, our consent form, and kind of what we go over with a patient or with a client for surgery. Admission form, like I said, we have the client's name, the patient's information. So with the patient information, what's stated is the signalment of the patient. So this patient is Bella, is a feline domestic long hair. She's female. It's coming in for a spay. It's a calico, and her weight last time she was here was 4 pounds and 12 ounces. For permanent patient records, we have Cornerstone, which is our database that holds any and all information on patients. If they come in from another clinic, or if they are just here for like a referral, so sometimes we have referrals of radiographic studies and stuff like that. So if they come in, we do get permanent records from the other clinic and then scan them into our system. So this is actually my dog Remington. So it has all of my information here. So the owner's information here. We have all the pets that they have listed here. And then we have this specific patient is Remington. It has a signalment here. And then we can also have our reminders that are due, our microchip or rabies tags, any scheduled appointments, any boarding appointments, the last time they were here, our patient visit list, so our bills, our estimates, any reminders or any notes or allergies. So this has what they're allergic to, or any grooming or anything notes, temperament notes, anything like that. This is all the owners, so we can put percentages of owners. So if I had another person that owned my dog, so like if my mom would bring him in, I could put her as 50% owner, so it would come up on both of our files. And then any referral vets. Here we have our summary of everything that's been given or done to Remington. So we have everything that's been done, anything that's been given, the vaccinations, medications and stuff like that. Any problems that have arisen, so if they come in with vomiting or diarrhea, you can put it in as a problem. That way we can, once it's diagnosed, it'll take it off and put it in a diagnosis. Here's the diagnosis. So he was Ehrlichia positive in 2017. This is all the prescriptions that he's had, all of our medical notes from the doctor, and this has everything on there. Any labs that have been done, vaccinations been given, vital signs that we've taken, and then we have Vet Connect Plus too. So that is, if we did have records from another clinic, it would be scanned in here. We also scan in, like if we refer them anywhere, we get the records from where we refer them to. So if we refer a lot to MedVet, where they do specialty medication up there, so they always send us updates, so we'll scan those in so that they're in the system. If we do any surgery, we do scan in our anesthesia papers, so they're easy to find. So to make sure that we have the right patient with the right procedure or diagnostic or anything that they're here for, we always use a cage card. So what the cage card has on it is it has its name, the signalment of the patient, so the breed, sex, age, and color. We also have the owner's information here, so their account number through us, their name, and their phone number. This goes on the cage card holder of all cages, and it goes on them when the patient goes in. So as soon as the owner hands us a patient, we bring it back, put it in a kennel, and put the cage card with it. We also, prior to taking the owner or the patient from the owner, we make sure that the patient matches the description. Same thing whenever prior to getting the patient out, we always make sure that the information on the card matches the patient. Alrighty, so we are going to do pre-surgical blood work on Rapunzel. So I'm going to show you how to pull up the system to send it out. So we use IDEX for all of our in-clinic and outgoing labs. So what we're going to do is we're going to put it on her bill, so the patient visit list. We put the code in. We're just going to do a pre-surgical panel. What that is that's our minimum database for our clinic. It's a CBC and a chemistry 10. And when we send it out, they also check SDMA. So we are going to put it in. Click OK. And it's going to pop up our IDEX diagnostics, how we order the test. So we make sure it's for Rapunzel, the Young Wellness, which is what the pre-surgical blood work is called. It's a Chem 10 with an SDMA and IDEX CBC. Then we hit order. This pulls up print lab request. So we only need 2 pages of the full page, and we need 2 tube labels so that we can label both the purple top for red blood cell or CBC, and then the serum separator tube as well. And then we just hit print. After we get the blood spun down and get our papers printed out, we put our labels on. So the label, we write the source as blood. It has the requisition test, so the code number for the test, the client name, pet name, the signalment, so the sex, age, breed, the doctor who ordered it, which our doctor's out, so we have a relief veterinarian in today, so she ordered it, and the collection date. So that's on both the purple top and the red top. So what we do after that is we put it in our bag, and we printed out 2 of the full pages because 1 stays with us so that we can confirm that they did the right tests that were ordered. So So we fold the other one so that the barcode is what's showing. So we put it, IDEX is really neat because they have the little extra flap here that we put this in, so that whenever it comes in, IDEX can just scan it, automatically pops up with the pet's information and the test that we ordered. So after that, we'll put it in the box, and then we just close it up. We put it in our FedEx bag, and we send it, call FedEx, they come and pick it up. So we went over the admission forms and everything. So now we're going to go over an anesthesia paper. So what an anesthesia form has is it has our pre-surgical information and then our during surgical information with the post-surgery. So the pre-surgical information, first we have to make sure that all the information at the top matches the patient. So we want to make sure the segment that is noted here matches the segment of the patient that we're getting ready to get out of the cage. So we do our pre-surgical and pre-anesthetic exam. We make sure that they're healthy for anesthesia. We get vital signs. We score their procedural pain assessment and our anesthesia risk assessment. And then we do pre-anesthetic drugs. So cats that are here for routine surgeries like spays and castrations, we don't give pre-anesthetic drugs like ACE or atropine or anything like that. If they're here for a dental, we may do some atropine to help with the saliva. We do Telazol as an induction agent. We give that intramuscularly, so that is how we induce our anesthesia. And then sometimes we'll intubate with a tube, other times we can just mask and they're okay. We do a lot of masking just because it's a little easier on the patient, on the cat. So dogs, we intubate as soon as they're anesthetized, we do intubate. So it just depends on the patient. Miscellaneous drugs are our eye lubricant that we put on any and all surgeries to help protect the eye. Fluids, if the owner approves them. So we usually use sodium chloride, 0.9%. We mark the gauge catheter that we use. We usually use this left cephalic catheter or vein. We do how many drops per minute our IV line is. And then we can put our dosage over here on this side. We make sure we mark our monitoring method. So manual is always marked because we are always in surgery manually monitoring anesthesia, but we can use our esophageal stethoscope and our cardiac monitor as well. Pain medications, so for cats, for this specific patient, our protocol for surgery is going to be Onsior, so that's going to be our pain protocol. So Onsior we give at least 30 minutes prior to surgery. That helps with pain relief. And then we give it daily after that, and it's just 2 days after. So we would give it the following day and then one more day after that, and that's all the pain medication that they need. Antibiotics, if needed, we always give a PPG injection, just where they're going to be opened up. We want to make sure that we have some sort of antibiotic on board. If the doctor believes that we need an antibiotic for another reason, we can do it on here too. We can mark that. We also down here at the bottom have our emergency drugs. We always put a dose on here so that it's ready and we don't have to figure out a dose in the middle of surgery. But we only check mark if it was given, So we have our dopram and our epinephrine. And then we have our surgery options down at the bottom. So if they want pre-surgical blood work, we either hit decline with the normal limits or have our notes. Laser therapy, microchipped, and then we can write in any other surgery options. So if it's a mass removal, we can write in histopath, or if it's a cystotomy, we can write in our stone analysis or anything like that. So that way it's all noted. And like I said, the only time that we know that we have given a medication if it's checkmarked, we only checkmark if it's given. And when it's given, which make sure as soon as you give it, you checkmark it. So the next page is our actual anesthesia log. So this here is where we log their respiration rate with O's and our pulses with X's. So we have our numbers here. We measure every 5 minutes. We document, but we measure continuously. Then we make sure that we are writing down our isoflurane amount and our oxygen amount that's being given. Down here is our comments through the surgery, so our steps in how the surgery was performed. We do have templates to make it a little bit easier. We just always make sure that we do everything the same way. If something's different, we make sure we go in and change it. And then any additional notes. We have post-op care, which is our temperature. We do our post-op temperatures, and then our post-op notes. If they're boarded overnight or hospitalized overnight, we mark that too. So those are anesthesia forms that we use in our clinic.
So for patient release instructions, your dog had a spay today, so we spayed Sasha today. So what this is going to do is you won't have any more heat periods, no more unwanted puppies, so that's really nice. And this all goes over any information you want to know about it, any side effects or anything with, is it going to make their pet lazy or anything like that. Important things to watch for after surgery, you want to make sure we are free of intestinal parasites, so you're on heartworm prevention, that's really good. Vaccinations are up to date, so you want to restrict the activity for the next 14 days. No running, jumping, on leash walking only. Don't let them go up and down stairs, on and off furniture. You want to be really careful. Cage rest if need be. So we do have external sutures, so those need to be removed in 14 days. We want to make sure you watch the incision site daily for redness, swelling, or drainage. If anything's noticed, make sure you call the clinic so we can get you in for a recheck with the doctor. Make sure we keep the e-collar on at all times. The reason we do that is to make sure that they can't lick or chew at the incision site. They can eat around the e-collar if they're in your direct line of sight. You can't take it off long enough for them to eat and drink. Just make sure it goes directly on. We don't want them licking or chewing at the incision. We want to make sure that we gave the pain medicine as directed. So she is going to be sent home with carprofen. It's 100 milligrams. She'll give 1 tablet by mouth every 24 hours as needed for pain. She will need it for at least 7 to 10 days, and there is 10 days worth. So just make sure she gets that. Watch for any vomiting, diarrhea, bloody stool, anything like that. Those are side effects with it. So if anything's noticed, just give us a call so we can get her on something else. So, have any questions? No. Alright, so now I'm going to demonstrate how to restrain for different venipunctures. So the first one that I'm going to restrain for is going to be the jugular. So in order to restrain for the jugular venipuncture, what you do is you make them sit and then go into sternal recumbency, and you want them just off the edge of the table so that the technician that is drawing is able to get to the jugular vein properly. So you're just going to keep them down and keep the head up so that the technician then can get access to the jugular vein. That gives us a good clear view. You want to make sure you keep them straight, so if you can keep them up against you, that's the easiest way. Good girl. Next, we are going to do restraint for a cephalic vein. So what you will do, some technicians or doctors, they like for them to be either sitting or sternal recumbency. They're sitting as long as you keep a hold of their head to keep them up and away so that they cannot bite. And then you'll occlude the vein by putting your thumb right in the crook of the elbow, and you'll just gently roll out and go behind the elbow to push out the forelimb so that you can get access and you can see the vein very well. Okay, so for saphenous venipuncture, we're going to restrain her for lateral saphenous. So what we'll do is we're going to lay her on her side, go into sternal recumbency, or not sternal, I'm sorry, lateral. And we'll just hold that leg so she can't go down. And we're going to use one finger to push her leg out, and your thumb goes behind the stifle so that you can keep good control of it. So if you're behind the stifle, you can keep it pushed out. And you're just going to hold off right behind the stifle. So you'll just hold off to occlude that vein. And then the person drawing is able to draw really well. Her saphenous vein is popped out really well for them. So. Okay, so now we're going to properly show how to properly get a patient into and out of a cage. So you always want to make sure anytime you're moving around the clinic or anywhere, you want to make sure that they have a leash on. A slip leash works really well, just in case they were to get away from you, jump out of your arms or anything. So always make sure you have a slip leash on them. So you want to open the cage door, sit them in it. Keep a hold of them so that they can, if they were to try to run, you are still out of control. And you'll just keep them in there. And when you shut the door, you always want to pull it to make sure it's completely shut. So to get them safely out, you want to be very careful when you open the door. Keep your hand, slide your hand in so that you can get control of the patient. Slip your slip leash over, and then just pick them up gently. Make sure you're supporting the front end and the front end. So this is how we do it on a smaller dog. So if we were to do a larger dog, usually they're in runs. So it's kind of the same concept. You want to make sure you get a leash on, so you'll open the kennel or the run door, slip the leash over, and then just make sure you get them out very safely. And always use caution, because you never know how a patient will react when you're opening the door, if they'll run out or jump out or anything. We're going to safely apply a dog muzzle. So the small end goes on the top, the larger end on the bottom, and then the straps wrap underneath and around the head, underneath the ears. So with the really aggressive dogs, you want to be careful, obviously. It's a lot easier if you try to go from behind, because if they see you coming, they have a better chance of going after you. So if you just kind of wrap it around, I know you're sweet, and you just want to wrap it around the muzzle, and then you want to take the straps, clasp them, and then you want to tighten it up. You don't want it to be too tight, but you want it to be tight enough so that it doesn't fall off, and then that's how you safely apply a muzzle. So now we're going to show how to apply an e-collar. So you want it to be able to be 2 inches past their nose when you push it against their shoulders. This is a size 40. It's probably a little bit too big for Sasha here, but our 30 is way too small. So we would rather it be, especially with cases of surgery, you would rather it be too long than too small. Because if it's too small, they can still chew out the sutures and stuff. So what I like to do is I like to put the gauze wraps around the collar, and you tie it to it so that it stays on. So I like to put the gauze on prior to applying the e-collar, especially if they're awake, because they fight a little bit more if they're awake. If they're still anesthetized and you put it on after surgery, it makes it even more easy. You can also use bread ties or zip ties or something to help keep them on. So what you do, I know, is you just wrap it around. I get that backwards. You wrap it around their neck, and you want the flappy part to go on the inside, and then let me see if it's sleepy. You want to snap it. You still want it to be like 2 inches or 2 fingers between the e-collar and her neck, just like you would want with a regular collar. Okay. And then you want to take the gauze strips, and we're going to tie them to her collar. And you also want to be really careful. It's like I was sticking my hand in. You want to be really careful because e-collars are kind of make the dogs nervous. So you just want to be careful that you're not sticking your hand in whenever, especially on a dog that's already nervous, because they can bite out of fear, just because it's scary with something going over your head like that. Alright, and that's how you safely apply an e-collar. Now we're going to do a physical exam on a dog. This one had surgery yesterday. It was a spay, so we're just going to do the following day follow-up physical exam, just to make sure everything's going okay before she goes home. So we're going to listen to her heart and lungs. We're going to get her heart rate and her respiration rate, but I'm going to also oscillate the heart and lungs while I'm at it. Alright, so her heart rate is 100. I'm just going to listen to the rate chambers of the heart. We're listening for any softening,
for muffled sounds. Everything sounds really good, so now we're going to listen to the different chambers of the heart. They have 9 chambers, or the lungs. So everything sounds good. I don't hear any wheezing or crackles or anything, so everything sounds good there. And the respiration rate is 20, so we're just going to note that. Alright, and I'm also going to check her femoral pulses to make sure that they're even. I'm just going to use my 3 fingers on the inside of the femur. Everything feels really good there. And her incision looks perfect. And the last thing I need is her temperature, and then we'll just check out and make sure that everything looks good on the front as well. Her temperature is 100.1, so she's good. I'm just gonna, hi sweetheart. Just check to make sure her teeth are awesome. She is young, she's only 6 months old, so her mucous membranes are pink and healthy. Her capillary refill time is less than 2 seconds, and her ears and everything looks good, really good. So she's in good post-op condition. Her ASA score that we scored her for yesterday was a 1. She is young. Her blood work looked awesome, and she has no issues at home. So, hey, sweet girl. All right. Now we're going to do a physical exam on a cat. So to start out, we're going to get a weight. And he can be contrary sometimes, so we're just going to see how far we can get on him. 8 pounds. Alright, so he's 8 pounds. So I'm going to get a heart rate, a respiration rate, and while I'm at it, I'm going to oscillate his heart and lungs. He'll smack if you rub. Alright, so his heart rate is 160. We're just going to oscillate his heart. We're listening for any muffled sounds. Everything sounds good there. So now we're going to listen to all 9 quadrants of the lungs. Listen for any crackles or wheezes. Alright, so now I'm going to just get a respiration rate real quick. The respiration rate is 40. He is young, he's going to be neutered today. He's a little over 5 months old. He has a little bit of gingivitis going on. He's got some tartar on his teeth too. Probably a grade 3, but his mucous membranes are pink and healthy. Capillary refill time is less than 2 seconds. His eyes look good, ears look good. So everything looks good. His ASA grade would be a 1 because he is young. His blood work, we did do pre-surgical blood work, so that all looked really good. So we're going to get him ready for... Okay, so now we're going to draw blood from the cephalic vein. I have a heparinized 1cc syringe with a 25-gauge needle. So Sydney is actually just going to occlude the vein and push the leg out to me so that I can get it. I'm just going to wet it down with alcohol. Alright, so this is just for a heartworm test, so I just need a little bit. We're going to draw from the jugular vein now. So you're just holding up, and I'm going to occlude the vein here. And we have just enough for our glucose test. That's all I need. Okay, so now we're going to get it from the blood from the saphenous vein. We're going to use the bevel up. Here we go. Now we're going to do a cephalic blood draw on a cat. We've got at least 3 drops, maybe a little more, but that is our cephalic blood draw on a cat. We're going to do a jugular stick on a cat. Alright, so we've got a little bit of blood from the jugular vein. So we're going to draw blood from the medial saphenous on a cat. So Allison is just holding off. And we've got our blood, enough for. Okay, so minimum databases are some parameters that we like to check prior to going into surgery. So a minimum database is usually a packed cell volume, total solids test, a glucose reading, BUN, and ALT. What we use in our clinic, our minimum database consists of a CBC. It also consists of a chemistry panel. It's just a Chem 10, so just some pancreas and kidney and liver, heart enzymes there. Just checking a few things so that we can make sure that the patient is healthy enough for surgery. That's for a young pet. Now, if we are a geriatric patient or one that has been sick, we recommend a full workup. If it's something that's been sick, we do the CBC, we do a chemistry 17 and an electrolytes. If it's a geriatric patient or something that the doctor feels we need to check a thyroid test, we do the Chem 17, the lights, CBC, and we do a thyroid check. So just kind of depends on the situation, the age of the patient, the health of the patient. But we do recommend pre-surgical blood work prior to any surgery. Some people do decline it and they refuse to do it. But we just always make sure that they know that without the blood work, we don't know what's going on inside the patient, so that we can help them metabolize anesthesia correctly and be able to handle the right anesthesia. Some additional testing or databases that can be added to depending on what the original, like the minimum database shows, like a geriatric patient or even a sick patient. If the doctor hears like a heart murmur or something, normally they recommend like an ECG, chest radiographs. We may need to add in ultrasound, urinalysis. It just all depends on the patient, the health of the patient, the age of the patient, and what the minimum databases show. So that's why it's really important to make sure that we do blood work prior to surgery, and routine blood work in general for patients. So our anesthetic protocol for Miss Bella, that is our cat that's going to be spayed, is going to be, we'll give Onsior prior to surgery for pain relief, for effective pain relief, and then we'll induce anesthesia with Telazol, maintain with isoflurane, and then post-surgery we'll give a penicillin injection and monitor for any issues that arise. And then the following day, they do stay overnight. Spays will stay overnight for monitoring, and then monitoring the next day. So the following day, we'll give the next dose of the Onsior for pain management, and then they can go home they can go home after that, and they'll have one more dose of Onsior. We do put an e-collar on right after surgery as well, so that they can't lick or chew at the incision and cause it to be infected or pull out the sutures. If we were doing a dog, normally with young and healthy dogs, we use acenatropine as a pre-anesthetic to help calm them down, give them some relaxation, and then we also use Telazol for them to induce anesthesia. We intubate with an endotracheal tube, maintain with isoflurane, and then we give a Carpreve and a PPG injection as well. After surgery, we will put an e-collar on too, so that they can't lick or chew at any incision sites, pull out any sutures or anything like that. And then the spays do stay overnight, just like the cats. They'll stay overnight, we'll monitor, and then the following day we'll give the next dose of pain medication. They go home with 10 days of pain medication. And then if there's anything that arises, the doctor will prescribe anything else. Now we're going to show logging in our controlled substance logs. So this is for Telazol. This is for the surgery that we did on Lily. So this has our Telazol. We put the date, the client last name, the patient first name, the client ID, the bottle number that we're on, the reason that we used the drug, the amount used, and then the balance. So we did this on the date, last name Benson, count number, bottle number is 62. She was sedated for a dental. We use 0.9. And then we do the balance. I always use a calculator, even if it's something simple. And that is how we log in our controlled substance logs. So this is our mobile anesthesia machine that we can move throughout the clinic if need be. So where we're going to start is we're going to start on these are our e-tank oxygen tanks. They go from the tank up through the hose into the flow meter. So we have our flow meter, which reduces the PSI down to 15 to be delivered to the patient. We have our flush valve right beside it. From there, it goes into our vaporizer. So this is our vaporizer, our precision vaporizer for isoflurane. So we have our viewing window here so that we can measure how much isoflurane is in the machine. We have our thing that turns it on and off here, our gauge that turns it on and off here. From here, it is delivered into our inhalation valve. So it goes into the inhalation valve. This is a rebreathing circuit. So there are two parts to our rebreathing tubes. So the inner part is the inhalation tube, and then there is the outer part, the exhalation part of it is surrounding the inhalation so that the the exhalation breath is warming the inhalation. So as it is breathed into the patient, and then as they breathe out, it goes up and into, it goes down in here and out the exhalation valve. This is our reservoir bag, also known as our rebreathing bag. So as the breath is exhaled, it goes into our exhalation valve. Excess carbon dioxide is absorbed into our carbon dioxide absorber, which is our soda lime. From there, it is gone through the tube here. Our waste gases are gone through this tube here from our pop-off valve to our scavenging system, which is charcoal. So our excess gases, waste gases are absorbed there. Back to the pop-off valve. So the pop-off valve is what helps them measure the amount of pressure. It helps so that too much pressure is not built up into the patient. If it is completely off, pressure builds up and keeps building up, and that can expand the lungs and cause damage to the lungs. So we want to be careful that this is always on. If we are rebreathing for a patient, you'd close it completely, breathe, but we don't want the manometer, which is what measures the amount of pressure that is being delivered. We never want this to go up over 20 centimeters of water. So we just want to make sure that we monitor that. As soon as we give the breath, we want to open the pop-off valve back up. So we want to make sure that that always stays open so we're not building up too much pressure in the patient. So to perform a leak test on our anesthesia machine in surgery. So to do that, we're going to put our hand over the port at the end. We're going to press the flush valve and watch the pressure go up to 20 centimeters of water on the manometer here. And then we're just going to hold it there for 5 to 10 seconds. As long as it doesn't go more than drop 1 centimeter of water per second, then we know there's no leak. So it's actually holding pretty steady. So now we're going to open the pop-off valve and watch our back deflate, and we know that it's going into our scavenging system. Okay, so for the esophageal stethoscope, we're going to pull the tongue straight out, and we're going to place it right beside the trach tube. We have the monitor, or we just hook it up. Okay, so whenever we are doing orogastric, or if we're doing gastric intubation, you can either do orogastric, where you go down the esophagus, or you can do nasogastric, where you go in the nose and down. So the reason we do gastric intubation is to either release pressure from fluid or air in the gastric region, or tube feeding, or charcoal administration for toxicity. So to do this, what we do if we do orogastric, we just go straight down the esophagus and keep going to the stomach. You want to make sure you're in the stomach and not in the trachea or anything, and to do that you can confirm it because you'll have gastric contents coming up. You'll also have the gastric smell. So to measure how long you need it, you want to go from the last rib to either the end of her nose or the end of her mouth, whichever you're going to use, and then you just mark it. You can mark it with a Sharpie because this is not sterile. It's not something you're going to be doing sterilely because it is going down her nose or down her mouth. So we would just mark it, and then we would feed it down to that mark, and then we can either release pressure or release fluids, or give force feed via feeding tube, or administer charcoal, whatever needs to be done. And this is just a red rubber gastric tube that we would be using. She doesn't actually need it. I'm just demonstrating on her. So whenever you put this in, you want to make sure that their neck is not hyperextended, because this can cause issues as well. And then you just want to make sure that you confirm you're in the right place. And we're going to perform an ECG on Pumpkin. He is sedated with a low dose of Telazol, so that I can perform it safely. So we can be a bit aggressive. And we have the old school Cardell monitor with the ECG machine on it. So we have the 4 clamps, and they are pretty metal clamps, so they're not the most comfortable when they're awake. So it's easiest to do with sedation. So he is in right lateral recumbency. So we're going to place our clamps in their appropriate places. So the green goes to the left leg, or the right leg, I'm sorry, just at the stifle. The white goes at the front, just by the elbow. Red is the left leg, and black is the right leg. We're just going to let them down. So we're just gonna let this warm up, get a good reading. We can minimize artifacts by moving distally on the leg. If we're up too high, it can have artifacts. So what we're looking for is we're looking for any arrhythmias. They can have regular, irregular beats, or irregular arrhythmias. Sinus arrhythmias they can have a normal one. So we're just looking for that. Alright, so we're going to fit a trach tube on Sasha. So in order to do this is not an exact science. It's a good guesstimate. So what we're going to do is we're going to put it between her on her nose, between her nares, to see if the size is correct. And usually it fits pretty well. So I know it's weird, isn't it? So you just want to put the end of the tube right between the nares, and that actually fits perfect. So this is a 33 French, so this is more than likely the one that we would use. It may still be a little big or a little small. Now, so to check the endotracheal tube for leaks, what we do is we're going to fill the cuff up, and that blows this part of it up, and we just want to make sure that no air is escaping from it. So this isn't going down, and neither is this. So we know that there are no leaks. Especially when we take the thing off. So to inflate this, the reason we inflate it is so that oxygen or gas does not escape the esophagus whenever they are intubated. So to inflate it, what we do is we pull air into our 12cc syringes. Work awesome. And then you just put it on the end and you put air in it. You want it to still be able to squeeze a little bit. You want it to give a little, but you don't want it to give so much that you're able to pinch it down completely, because then it's not inflated or it's leaking. So you don't want to overinflate or underinflate. Overinflation will cause tracheal damage. So you want to make sure that it's not overinflated. So about right there is perfect, because you're able to give a little, but not outrageously amount of give. You're so sweet. And then to deflate, you just put it on and you suck the air back out. You want to make sure that you get the air out before you take the trach tube out every time. So you always want to make sure it's deflated before taking it out, because if it's inflated and you take it out, it can definitely cause some tracheal damage. So to do blood pressure on Sasha, so on the blood pressure cuff, we have it on the front limb. So we just want the inside part of it. So we want this little line here to be in between the optimum zone. So this actually fits really good on her. And then we're going to turn ours on. So we need, I don't know if we can see very well, but we want it to be green for forearm and red for dog. So we are on there. We want to purge it to reset. This is an older school one, but it still works great. So we're just going to squeeze up. Maybe. And we want to try to get them as calm as possible. So usually we like to do this before we do any prepping for the doctor or any physical exam. All right, so our first one is 115/70. And our mean arterial pressure, MAP, is 80. So we like to do this 4 to 5 times if the patient will allow it. The reason we do that is, unlike humans, we can't tell them to sit still. So each one is not a great one, unless, you know, they're like sedated or something, and then it's going to mess up with the sedation. But so we're going to take it try to at least 4 times, and then we cross out the skewed one, and then we find the average between the rest. Alright, this is the last one we're going to take. It is 135 over 70, and the MAP is 85. So they're all pretty much the same, but we'll show you how to average them out next. So now that we've taken the blood pressure on Sasha, what we do is we find the average. So we're going to take a look at these, and we're going to find the one that's most out of whack, which I believe is going to be the 115 over 70. So we're just going to cross that off. And then we're going to take the other 4, and we're going to find the average of them. So we're going to do which is 79. And that is how we do blood pressure on a dog. In the ECG, blood pressure, gastric intubation, and the esophageal stethoscope. So I'm going to show you now our thermometer probe, which you saw during surgery. But it is hooked up to our Cardell monitor. So this is the probe that goes into the rectum of the patient, and it measures the temperature throughout the entire surgery. Alright, so our oxygen, our pulse oximetry, it measures the wavelengths of hemoglobin in the blood. So we just put it, we're going to use it on my finger to demonstrate. So it gives us the percent of oxygen. My oxygen level here, so the percent of there, and it also measures our pulse. So the way that we measure our heart rate in surgery is with our ECG probes. It shows us our heart rate. It also monitors respirations. So that's really nice, but that's also why we do manual checks too, to make sure that it is correct. I just want to clarify on the video what the pulse oximeter does. So the pulse oximeter uses infrared and red light to measure the amount of hemoglobin that is saturated with oxygen. I said that incorrectly on the video, so I just wanted to clarify. Hi, this is Dr. Kidd. She is my preceptor for the entire courses through Cedar Valley, so she's been awesome and has helped me a lot.
I'm glad to be with Autumn, so we're having a good time, aren't we, Autumn?
Yep. Now we're just going to open, make sure it's flush fine. And our drip is going, and it's not blowing up, so we know that the catheter's in correctly. So we're just going to take the catheter up and out of the way. There we go. Okay, so now we're going to place a saphenous catheter, so we want to shave first. And we like to shave all the way around so that the tape doesn't get stuck to the fur, because that can be painful when he's waking up. I'm going to take the catheter out. And we have our tape ready, we have our catheter ready, and our fluid. And you always want to make sure there's no air bubbles, so I am going to let this run for just a minute. Alright, so now we're going to surgically prep and scrub. Just like you would an incision site. Alright, so what Jody's going to do is she's going to hold off the vein for me to make it easier. And you can see the veins popping up. Can you unscrew that for me? So to hold this in, what I'm going to do is I'm going to take my smaller piece of tape and go underneath. And around. And this secures it so that it can't go anywhere. And then we're going to take our 1-inch tape and we're going to slide it under just to hold it there. Hold it more in place, and you don't want to do too tight. All right, now before I do the last tape, we just want to open. There's a little bubble, so. And just getting the bubble out. Sometimes bubbles back up into it, so make that tight. And just show that it's running good. All right, and there's no bubbling up where the around the legs, so we know it's in place. So now we can get the drip down to where it needs to be, and we're just going to secure this into place so that it's out of the way with our final piece of tape. Sub-Q injection. So this is just some sterile saline, since she doesn't really need an actual injection. So to give this sterile, or to give a sub-Q injection, what you do is you just pull the skin up, tint it up. It'll make a little tint, and there you go right into the tint. You want to be careful not to go all the way so that you're not going completely through the skin. I know. You want to pull back to make sure you don't get any bubbles or blood, and then just inject it. Good girl. And that's how you give a sub-Q injection. So now we're going to give an intramuscular injection. This is ACE and atropine. It is our pre-anesthetic protocol. It's a tranquilizer. So we're going to give it IM. So what we do is we have a restrainer hold the head so it stays still. You want to support the femur, and we're just going, I do a little shake just so they can't feel it coming. So we're just going to go right into the muscle. You want to pull back to make sure there's no blood, and then just inject. And that is how you give an IM injection. All right, so we're going to put Remington under anesthesia now. I'm going to give 0.2 mLs of Telazol. It's talamine and zolazepam, so it's a generic version. So we're going to give this IV. So Jody's just going to hold off. You want to make sure there's no bubbles. You're okay, buddy. And he had some acepromazine, so his blood pressure is a little lower. So. So you're just gonna pull back and make sure you get blood, and then she's gonna let off. Alright, so there is the IV injection, and he's gonna slowly go down. Okay. Now I'm just gonna push the epiglottis down. Alright, so we know it's in because we got some air coming out. I'm just gonna hook him up, turn oxygen on, turn some anesthesia on. We're going to secure the tube with a rubber band, put it up and over his nose, and then we put it behind his canines to keep it in place. We're going to, I need a 12cc syringe. That'll work. So we're just going to blow up the cuff. By that, we're going to pull it back, which we already showed, and just put a little bit of air in. We're not going to overinflate, but we don't want to underinflate. Alright, so we're just going to put the lube in the eyes. He is sedated. We may have to mask him a little bit because we did a low dose of Telazol. The reason we lubricate is because cats don't blink during surgery, or once they're sedated, so we want to make sure that they stay lubricated and we don't have any abrasions that happen from it. So, alright, so now we're going to shave for the spay. I need to express her bladder. She's already trying to empty it, so I'm just going to gently express it. Alright, so now we're going to shave. So we're going to start the shaving right at the end of the sternum. So now we're going to do our surgery scrub. So we want to scrub at least 3 times, but however many times it takes to get her clean. So we're going to start at the incision line, scrub there, and then we go to the outside around. So you want to scrub the incision line, and then go out and around it. Okay, now we're ready for surgery. Alright, so now we're going to transfer her to surgery. We need to keep this sterile field sterile, so we're going to keep her in dorsal recumbency and just support her head and keep her in the feed trough. Alright, so now we'll do our surgical scrub. Alright, so now we're going to do our surgical scrub inside surgery. Alright, so we're ready for surgery. Alright, so with the spays as well, we want to make sure that we're monitoring our heart rate and respiration rate throughout the whole surgery, but we document every 5 minutes. We have a thermometer probe attached to our Cardell monitor, so I can monitor that throughout the whole surgery. You have to take it at least every 15 minutes, but we can monitor it continuously with this. And then we've got it hooked up with our pulse oximetry and our ECG machine, all on the Cardell monitor, so we can monitor all the vitals all together. Monitoring the vital signs, we also do manual checks, so we watch the rise and fall of the chest for the respirations, and we use our stethoscope to get a manual heart rate at times, just to double check that our Cardell monitor is working appropriately. And then you always want to make sure that you're watching the mucous membranes, capillary refill time, and we'll check pulses at times too. The lingual pulse is the easiest to get to, especially during this phase, so that we're not around the sterile field, so we will check that as well throughout the surgery. If a patient goes into cardiopulmonary arrest, resuscitation needs to be performed immediately. So in order to do that, Pumpkin does not need it. He is just going to be my little model. I'm not going to actually compress on his chest. He's recovering from anesthesia. He's doing well. He's doing great, actually. So if they're less than 15 pounds, we can use the hand method, where we use our whole hand, not just our fingertips, but our whole hand, go over the heart just behind the elbows, and we want to compress on the chest. You want to do 30 to 40% compression, let it recoil between each compression. You want to do, for cats or small dogs, you want to do 120 to 130 compressions per minute. Now for larger dogs, to do it, you would do the two-handed method. So in order to do that, you would go a little bit caudal, then you do for the smaller animals, and you would go to the widest part of the chest, and you would just press down. Again, 30 to 40% compression each time of the chest, and let it recoil. So if by chance they have an endotracheal tube in, then you can hook it up to an ambu bag, where you hook it up this way. You hook it up and you breathe for them. 8 to 12 respirations per minute, regardless of size. And if by chance you have an anesthesia machine close, it can also be hooked up so you can deliver 100% oxygen to them, and you can breathe for them again with a reservoir bag, 8 to 12 breaths per minute, regardless of size. But we do not want the level to go over 20 centimeters of water. So that is how we do cardiopulmonary resuscitation. Okay, so to start out, we're going to open our gloves and our gown. So we know that this is sterile because it has the black strips on the marker tape. So to start out, we want to make sure that everything's screwed over. So you want to be really careful that we don't break sterility. So you never want to go over the open part. So you just want to grab the flaps. Okay, and then we're going to do the same thing with the inside. Alright, so that's ready for us to put on. With the gloves, we open the outside portion. Now we just want to keep sterility. Alright, so those are ready for us to go. We are going to scrub in for surgery now. So we use surgical rub here. So we just have to wash our hands with antibacterial soap to start out. You want to make sure you wash up to your elbows. So now we're going to scrub in. Our hands are clean, so we're just going to, like I said, we have the surgical rub. So what we do is we follow manufacturer's recommendations on how to scrub in. So we do one full pump, which is 2 mLs, in one hand. We dip our fingertips in it and clean them. And then we take it and rub it over the rest of our hand, making sure that we start with our fingers. And we want to make sure that we hit all 4 sides of our fingers. And we want to make sure that we rub 10 to 15 times each time. We do our next pump in the hand that we just cleaned, and do the same thing with the opposite hand. So for our third and final pump, now that everything is scrubbed in, we do one final scrub, do a full pump, and we just do all over our hands and arms again. We are going to do a closed glove gloving, so we want to make sure our hands are completely dry. Makes it a lot easier when you put your glove on. Alright, so to grab the gown, what I'm going to do is I'm going to grab the strings and pull it up. And Allison's going to tie me up. Alright, so to do the closed gloving, what we do is we keep our hands in the sleeves. We're going to grab it. We're going to do palm to palm, thumb to thumb, and fingers pointing our way. And we're going to grab, hold the one where it's palm to palm. We're going to hold it in our hands if I can. And grab the other side of the sleeve with my other hand. And we're just going to pull it over. Okay, now with our gloved hand, we're going to go underneath the sleeve on this one and lay it the same way, palm to palm, thumb to thumb and fingers pointing towards me, and we're going to do the same exact thing. Alright, so we have our instruments set out here. We have a pair of hemostats, we have some towel clamps, and our needle holders. So we're going to put our blade on our holder. So you always want to use the needle holders because that is the only thing that is able to hold metal correctly. So we're just going to slide it on until it clips. Alright, and now this is ready for the surgeon. And then, so to pass an instrument, the scalpel blade, you want it to point towards you, but the sharp edge away from you. So you want to hand it off like this, so that the surgeon. Now for, say if I needed to hand a pair of hemostats, you want to hold the box part. So you want to hold it like this so it doesn't open and close, so that the surgeons can just grab a hold of it. Like that. Okay. We also want to make sure that we count our gauze first thing, so that we know how many gauze we start with and end with. So we have 1, 2, 3, 4. 13. We have 14 gauze, so we just want to make sure we end with 14 gauze. Now, duties of a sterile technician, when we are waiting on the doctor or moving around, we want to make sure that we keep our hands closed so that we don't touch anything else as we move around. We want to move around as little as possible, and if we were to break sterility, whether it's a tear in our gloves or if we drop an instrument or anything like that, we never want to grab an instrument as it's falling, because it is going into a non-sterile field. And if we do tear a glove, we can re-glove over it, or you can use the assisted method where the other sterile tech or sterile doctor helps you re-glove, as long as sterility is not broke. It is easier if you just glove over. If you break sterility with your gown, then we have to re-gown. So we always just want to make sure that we're really careful and try not to break sterility, but accidents do happen. We just want to make sure that we glove or gown or re-drape or anything if it does happen. So now we're So with our anesthesia machines, we want to make sure that the oxygen gets turned off. We're going to use the flush valve to let all the oxygen out. We're going to make sure that the oxygen machine gets turned off and our table's turned off. Now that we're done with surgery, we are going to clean the surgery suite. So what we do to start out is we're just going to wrap up all of our instruments and stuff. We need to make sure that we count our gauze. We have 14 to start with, so we have 1, 2, 3, 8, 9, 10, 11, 12, 13, 14. So we started and ended with the same amount. Alright, so I'm just going to set this outside of the surgery suite and we will get back to cleaning it. So the next thing that we do is we get the rest of the stuff that's laying around. So the next thing we do is we spray everything with our disinfectant. We want to make sure we clean all counters, all trays. So to clean the lights, we want to make sure that we don't spray anything on them, but we do use just a wet towel. Clean them off really good. So with our monitors, we want to make sure that all the cables are put up, which I've already done, but you just want to double check to make sure everything's clean. The first step in cleaning surgical instruments is the pre-soak. So we have our instrument tray with our instruments in it. We have distilled water and our IMS Spectra soap. This is specifically for instruments, surgical instruments to clean. It is a rust inhibitor too, so it helps make sure that the instruments don't rust. So we let this soak. Usually we let this soak for 15 to 20 minutes and then we will clean. Now that our instruments have soaked, what we're going to do is we're going to clean each instrument. While it's soaking, we do make sure that the box locks are unlocked. So we make sure that they are open. So whenever you clean, you just want to use your brush. And you want to make sure that you leave it open so that you can clean the box lock. You want to make sure you get in between on the grooves of the instruments as well. Is to rinse our instruments. We want to make sure that we use distilled water to rinse them. After our instruments are cleaned and rinsed, we put them in our ultrasonic cleaner. And we turn it on to set the timer for 20 minutes. So to wrap a pack, what we do is each pack, there's different packs that have different recipes for how instruments go in. So we have different instruments here. We have thumb forceps, we have needle holders, the Mayo Hagar needle holders, we have blunt scissors, we have Hartman mosquito forceps, we have Kelly forceps, Abson thumb forceps, the back offs, towel clamps. There are many different instruments. So So we have everything that's curved facing towards me until we get to the towel clamps. The towel clamps will face outwards. And then inside we have our thumb forceps at different places, our needle holder, and our scalpel blade. So we're going to place this in the instrument pack. And we want this bay hook to be on top, and we want the handle part of it to be up. We're going to place our sterilization strip in there, and then we're going to place a stack of gauze as well. Now we're going to wrap. So to wrap, we're going to pull the bottom up. I'm going to fold down and then fold the lip back up because this is a larger drape. We're going to fold the side over with a little flap. Same thing with the other side with a little flap. And then we're going to fold the top and tuck it into the flaps that we've made. Then we're going to do our double wrap, so our second layer of wrap. Now we're going to fold our clean gown for sterilization. So in order to start, we have it laying flat with the sleeves out straight. We're going to fold the outer edge into the center. And we're going to do the same with the near edge. We're going to do the same thing again. Okay, so now we're going to fold it in half lengthwise. And now we fold it into thirds. Accordion style. And we make sure that these are facing, our ties are facing up and ready. So we have our sterilization strip. So when it is sterile, this turns black and it says OK instead of just O. We have our drapes to wrap. So we place this in a center with our OK straps, or our OK strip in the center with it. And we're going to take the bottom edge. And this one's a little bigger, so I have to fold it a little different. So I've got it up and I fold it down. I fold it back up and then I have a little flap facing down so it's easy to pull up. And then we do the side the same way. With a little folded over. And again. And then we fold the top down. And this gets tucked into the top. Like so that we can grab this and we double wrap. So we just perform that again. And then we use our indication tape. This indicates that the instrument or pack or whatever is sanitized. So I like to write on it before. So we're just going to put gown so that we know what it is, today's date, and our initials. So we know who wrapped. And then it's ready to be on. Now we're going to place items in the autoclave. So when you're packing the autoclave, you want to make sure you do an even layer. You don't want anything overlapping. You don't want to shove everything in there because then nothing gets, or it doesn't sterilize correctly. So we're going to place our gown in, maybe our pack. Okay, so our pack won't fit. We're going to place, we have a small pouch of towel plants that we're going to just sit in there as well. We want to make sure that our reservoir is filled up to the green. With distilled water. Shut the door, make sure that the latch is on. We're going to hit packs because we have a pack in there, and then start. Now it's going to fill the chamber and go through the sequence to sterilize. So we use a steam autoclave for our sterilization. So it uses distilled water, and the water is heated and then turned into steam. The steam then forces the air out of the autoclave and builds up pressure. The amount of pressure depends on what we're sterilizing. So it ranges between 15 and 27 psi. The heat ranges between 250 and 270 degrees. And then it takes 15 minutes for it to build up the pressure and build up to the temperature needed. Once that 15 minutes is done, it starts the sterilization. That lasts about 15 minutes as well. After the sterilization is done, then the door will pop open to allow the steam to escape and condense back down into water. That also takes another 15 minutes. And we want to make sure that the packs stay in there for that 15 minutes so that everything is condensed back down, the steam escapes, and the water is cooled down, or the temperature is cooled down so that condensation does not happen on or in the packs. The first step to monthly maintenance on the autoclave is to drain the entire autoclave. So we want to make sure that we find the drain plugs, and we want to empty the autoclave completely. So you find the drain plugs, you empty them, and then you pour half a gallon of distilled water into the reservoir opening, and then pour about 4 ounces of OmniClean Cleaner Plus is what we use. We're actually waiting on more to come back because we used all of it the other day whenever we did the maintenance on it. Then you want to close the autoclave door and turn it on. You want to select pack setting and then start and let it go through the whole. After it's done cleaning, you want to turn it off and then carefully open the door and be very careful because it'll be hot from the steam. And then you want to empty it again. So you go through the same steps that we did the first time. So you want to get the drain pipes out. You want to drain the entire autoclave, and then after you empty the autoclave out, you want to clean with distilled, or just rinse out with distilled water. So while the drain pipes are still draining or ready to be drained, you want to run distilled water through the reservoir until it comes back clean. And then you just want to replace the drain plugs, fill the reservoir back up with distilled water. After everything's replaced and there's more, or you've refilled the distilled water, you want to go through another cycle with packs, the pack setting, and let it go through another sterilization process, and then you want to drain and clean one more time. So you'll drain everything out with the drain pipes, wipe it. You want to clean the inside of the autoclave if you can, or as carefully as you can, with a damp cloth. It will be very hot because it just went through a couple steam cycles, so you just want to be really careful. Then you refill the autoclave with distilled water and you're... So the way that we know that a pack is sterile is this is the gown that we wrap. So we know it's sterile because it has the lines across on the tape. So that is the way that we know that it is sterile on the outside. Once it is opened in surgery, we will know that it is, we do a double check that it's sterile by our OK strips. So the strip that we put in, instead of just having the O on it, it'll have an O, and then it'll have the K, and it'll also have lines across it.
Okay, so now we're going to remove sutures on this kitty. She had a spay done a few weeks ago. They're actually 2 weeks late on getting the sutures out because the owners, they're catch and release cats, so she can't get a hold of them the greatest. So her hair's kind of grown over on it.
a lot actually, but it still looks really well. Move closer so we can see. So, see how the hair is grown over it, but the sutures, they're not red, there's no inflammation, swelling or anything like that. So it's still kind of hard to see color over some. So we're gonna take them out. Let's set that up. There we go. Sweet. Can you switch me places so you can hold the front? Okay. So we're just using our suture scissors, and they are in the forward interlocking pattern, so we're just going to trim a few off. And the ends are the ones that are the interrupted. Just pull out after that. Usually we remove sutures 2 weeks after surgery, but like I said, she couldn't get a hold of these guys until today, so. And you just always want to double check to make sure you got all of it, and her suture line looks awesome. Alright, now we're going to take it out of the other kittens.